Hello and welcome to the shores of beautiful Lake Lugano here in southern Switzerland, not very far from the Italian border. We're bringing you 3 very special episodes of GU Cast, posting as usual on our audio platforms, Spotify and Apple, but also on YouTube, which I really encourage you to have a look at for these episodes because of this beautiful part of the world that we're in. We're here because the APCCC, the Advanced Prostate Cancer Consensus Conference, is taking place physically and hybrid here in Lugano this week. This is a 2.5-day meeting that only takes place every couple of years in normal times anyway, and features the top leaders in prostate cancer from around the world who get together and deliver some fantastic lectures discussing the most contentious areas in prostate cancer and have a series of votes among the expert panel to try and reach consensus on some of the more challenging areas of prostate cancer. What we'll do over these 3 episodes is bring you some highlights, some interviews with some of the key opinion leaders and some of the delegates to talk about the most important topics we've had discussed at this year's meeting, and also to get a flavour for what sort of research is being done and what direction that research will take us. So I do hope you enjoy these 3 very special episodes of GU Cast. We shall bring you similar episodes of GU Cast with conference highlights as meetings get going again later this year. Enjoy. So I'm joined by Silke Gillessen, who's the chair of the meeting. Congratulations, we're all here in person, Silke. It's very exciting to be in Lugano for the APCCC. The meeting kicks off tomorrow morning. Are you happy so far? Your faculty seem to be here and you've got a great program.
Yeah, so we started off today with a translational day. So this is the first time we did really also some translational research. And already that was really nice. I think it's like 160 people in person and then 200 virtually. It's really nice. And tomorrow the real one is going to start. And I'm like absolutely excited. And it's so nice because almost everyone is here. So there's some people who are sick or couldn't come because of institutions, but really most of the people are here, including you, Declan. So we are super happy, and I guess we have so many questions to answer. And this time we did really the votings before, so we can really already discuss the results of the voting in the meeting, and that's a first. And I think I'm really interested how it's going to work out.
I think that's a good idea. So you still retain the format of the 10 most hot topics in prostate cancer, and you have all your experts speaking, but instead of us waiting until the final day and voting on the hot topics, instead you've asked all your experts beforehand to vote. So therefore during the meeting we get a great discussion about the votes. So you're going to put up the result on, in this situation, should we do a PET scan or should we combine this or that? So I think that's a good evolution. You're looking forward to that?
Yeah, I think, we did it out of necessity because of the COVID, because we didn't know who can come, who cannot come. But I think now it's actually really nice because you can think about the results, so you can discuss already the results of the voting. And I think it's even more exciting. But we will see, what the other people think, so give us feedback. Well,
we're here on the eve of the meeting and we're going to make a podcast to share with our viewers some of the flavour of here in beautiful Lugano and what's happening in the meeting before, of course, the big manuscripts comes out in a few months' time.
Yes, hopefully. Thank you very much.
Good luck.
Thanks.
Good morning. We are reporting from Lugano from the APCCC 2022, and I have Declan Murphy here with me. Good morning, Declan. How are you?
Good morning, Derya. Nice to see you in person.
Yeah, very nice. So we had the first day yesterday. What is your takeaway?
It was a great opening session that you and I were both involved with, and the focus was high risk, locally advanced prostate cancer, recurrent prostate cancer. So for me, the theme that ran through the whole session and indeed the whole meeting was about PSMA PET imaging. We never get sick of talking about it. It was the disruptive nature of it. And I think that first session that we were on the panel for really struggled to know, how do we know what to do? What's the management impact of PSMA PET for these newly diagnosed men? What was my take on it? They kept referring to data like the Pro-PSMA trial, the US registration trials, but still people said, don't incorporate your PSMA PET too much into clinical practice. All the data from showing patients benefit is based on conventional imaging. So I struggle with that, of course, because like you, we have lots of access to PSMA PET. We've run a big trial on PSMA PET showing it's more accurate. And I felt that we're not quite there yet in convincing the panel that we should just be fully embracing PSMA PET. For example, Nicolas Motte, who we greatly respect, the chair of the EAU Prostate Cancer Guideline Committee, insisted that we should really still only be using PSMA PET in clinical trials for these localized prostate cancers. Whereas we feel that we've already done the work to show it's more accurate and that we just need to embrace it better in clinical practice to maybe hopefully make better decisions for our patients.
Thank you. So the point of Nicolas Motte was that while we showed it's more accurate, we didn't show that it leads to better oncological outcomes. What would you reply to that?
I agree with him, and it's right to say that, but as you and our viewers and listeners know, if you have a localized prostate cancer, even if it's high risk looking, so dangerous looking cancer, to prove that it's really going to improve an outcome, for example, the development of metastases in a patient, it takes so many years to do that. It takes like 8-10 years to do a trial that would show the decision you make at the start will improve outcomes out there. So that was what I thought yesterday, is we need to accept that it's impossible to do that. And when we now have widespread access, reimbursement in many countries for PSMA PET, we can't just deny the fact that it's more accurate and fail to embrace it in practice somehow. But I accept what Nicolas says, that yes, we have not shown that PSMA PET improves outcomes for these men. And for example, the Pro-PSMA trial in Australia never set out to do that. It wasn't the endpoint of the trial because it would take 10 years. But instead, I think because of this accuracy thing, it's more accurate. And because of less radiation dose, less equivocal findings, better cost effectiveness, we have to somehow embrace that and then work together in a patient-centered way, shared decision-making, to try and say, well, here's the information we have. It's more accurate than old-fashioned scanning, and here, therefore, is what we think are your options to manage it. But it's hand on heart. You have to say to patients, we actually haven't shown in a trial that using this type of imaging will improve your outcomes. Well, come on. Surely. Everything in life is about accuracy. I like telling using the parallel of, if you're in London, in central London, and you're going out to your friend's house for dinner, how are you going to figure out how to get there? Are you going to dig out the old London A to Z map book and figure it out, or are you going to go on Google Maps? You're going to go on Google Maps, but there's no evidence to show Google Maps is better, actually. That's the way I think with PSMA PET. We must use it judiciously, but it's just not feasible to try and design a trial that will show we improve outcomes in early prostate cancer.
Thank you. And the only point to add is maybe I think people are skeptical also because it's not so much available in their countries as it is in Australia. So one other point was the discussion of adjuvant versus salvage treatment in node-positive disease patients who received radical prostatectomy and had PN1 disease. So do you think adjuvant radiation has a role in that space?
Oh, yeah, I'm flattered you're asking me the question, but for anyone who was watching the conference or who's been here at the conference, it was Dr. Tilki from Hamburg who covered this session yesterday brilliantly. So look, I think in the discussion about post-operative radiotherapy, if we just take that as a discussion, men who've had a prostatectomy and we consider will they benefit from post-operative radiotherapy, I think by and large for those men, the 3 big randomized trials that read out a year and a half ago have shown us that for most men, early salvage radiotherapy, when the PSA reaches 0.2, is just as good as adjuvant. So we should, I believe, really not use adjuvant, except for maybe the select circumstances you referred to. The PN1 patients are different, aren't they? So they have patients who had a lymph node dissection, and yes, N1, they've got cancer in the lymph nodes. But I think what you showed very convincingly yesterday is that the natural history for some of those men with very low volume node involvement may actually be quite indolent, and even 10 years later, a significant number of those men may actually never have relapsed. However, for a certain proportion of them, certainly as the lymph node count goes higher, maybe especially associated with adverse factors in the prostate like high-grade T3B positive margins, clearly post-operative radiotherapy may be considered in an adjuvant environment prior to PSA. But I think your data, your new JCO paper recently published, does really focus the mind on the value of adding in radiotherapy for the PN1 in select cases. What do you think? You're the key opinion leader.
Yeah, actually, you summarized it very well. I think in these patients with more than 1 or 2 lymph nodes, adjuvant radiation really should be considered, especially if it's also combined with other adverse pathology factors, Gillessen 8 to 10, PT3B disease. Yeah, so I agree with that. Thank you for being with us live here from
now that we're
Lugano.
in a physical meeting,
Yeah.
how are you enjoying coming to a physical meeting? I have to say, it's so nice to see people like you and all our friends in
it's really nice,
person.
but it's a little bit for me coming from Germany where everybody is still wearing a mask.
Yeah.
It's a little bit unusual to be without mask. How is it in Australia?
Oh, we still pretty much wear masks everywhere. Certainly in the clinical environment, in the hospitals, in the consulting rooms, we're still wearing masks and being careful. But I suppose we're reassured by high vaccination levels. And I was in Europe last month as well, Derya, and got a proper dose of COVID. So I feel I've got some immunity at least for a few weeks.
All right, thanks a lot. It was great to meet you here live again.
Thank you.
Thank you.
Good, so it's a great pleasure to be joined at APCCC by old friend Dr Jochen Walz, urologist from Marseille, and Dr Pierre Blanchard, radiation oncologist from Gustave Roussy. Are you enjoying the meeting?
I do very much. It's a great meeting, it's a great faculty, great program, great venue, everything you're wishing to have during a successful meeting.
And it's nice to be back at a physical meeting
It
here.
is great to see colleagues in real life, yeah.
Okay, so you guys were involved in a couple of fantastic sessions yesterday and today. Jochen, I want to ask you first about your thoughts on local failure. You had a great talk about when we have failure in the prostate after previous radiotherapy, what are our options? One of the things I thought that was most important that you emphasized was doing nothing is perfectly okay. Can you talk to us a little about when you see a patient who's had radiotherapy sometime in the past and when they're coming to you with a raised PSA, what do you think in trying to assess these patients? Am I going to do scans? Am I going to do a biopsy? How do you figure out who you should be offering treatment to or who maybe you should just reassure from the start?
Indeed, the first point is to make sure that this patient would need treatment or might be a good candidate for treatment. Some patients say, I had enough and I don't want to have any intervention anymore, so it makes no sense to go further into the process where you might do a local treatment. And if the patient agrees basically that there might be a treatment on the prostate once more and he has an idea what the side effects might be and he agrees to the process, then I start to prepare the patient for what we need to have a clear idea what the current situation is. And then I would go for good staging, the most reliable that we have, which is PET PSMA, obviously for this patient. I would go for prostate MRI to see where the lesion is, get some idea how far it is extending, what the local situation is. Go for a biopsy, make sure that there's a local recurrence if it's really there. And then I would go also for a workup from the urinary tract, go for a cystoscopy, make sure there's no underlying problems up front that might make a treatment quite complicated afterwards. And if I have all this together, then I sit down with the patient again and then discuss, as I said yesterday, realistically what the outcomes might be from an oncological level and a functional level. And then the patient would need to think about it. And I would not operate or treat a patient right away after this discussion. I make him leave, think about it, come back, and then rediscuss, make sure that he really understood what might be the options and what the outcome is.
Because
and then he might
it's
decide.
not an emergency, there's plenty of time to
There's
think through it.
nothing else.
And look, I think you've given a brilliant way of how you would assess this patient in your clinic. But Pierre, one of the problems we're having, of course, is the increasing popularity of PSMA PET-CT. And we have many patients who've had radiotherapy many years ago, have done very well. PSA is slowly creeping up. Maybe it is a Phoenix definition of failure, and then they get sent for a PET scan and get sent to me sometimes then with this avid lesion. Now the PSA is 6 or 7. The patient's 78, has some significant comorbidities. What advice do you have about how do you select that patient? Because they're often in your clinic, in the radiation clinic, for that initial step, which all too often nowadays is a PET scan.
Yeah, I mean, the big question is what are you going to do with the result of that exam? And what was interesting in the session today is that there was a huge discrepancy between what the expert or what the panel think or does in general practice, which is they've said in close to 80% of the experts they would do MDT plus some changes in systemic therapy for some of those patients. Whereas the data is really lacking in this population, and we don't know whether metastasis-directed therapy will really bring something to those patients, whether that will have an impact on the disease outcome and the course of the disease. And I think it's very important in this population, if we want to use MDT, to make sure that we are not using a toxic treatment, so we want to limit the side effects, and we have to because we are not sure that we're going to provide any benefits, so we really need to have a low threshold of side effects.
I totally agree with you, and PET scanning sometimes just drags people down this trail where you can see an avid lesion, which probably was there for 5 years, so the radiation was 10 years ago, and then you're suddenly down a pathway of you're worried about it, and they might have expectations that the urologist is going to do a biopsy, and I've now read about cryo and HIFU and blah, blah, blah. But let's, finalising the options, Jochen, let's say you do have a fit patient who you think probably has a clinically significant recurrence based on the nice imaging you described and a biopsy, and has a very good life expectancy. Let's say it's a high grade, it's a post-radiation one, so it doesn't have a grade group, but it's a high grade cancer, quite high volume, right side of the prostate, localized to the prostate, in a very fit patient whose main motivation is not to have disease progression, and his PSA is now going up quickly. What do you think through in terms of your management options? What would you offer for these patients?
It always depends on how radical you would like to be, and the beauty of the surgery in there is that it probably is doing the best and the cleanest job locally. And probably all of us, we had those patients who were treated several times for local recurrence, had their first HIFU session, their second HIFU session, or their first re-irradiation, their second re-irradiation because it did not work. And then they end up with what I call the prostate cripples that do have like a necrotic prostate, fistulas, chronic pain, and these are quite challenging then to treat. Some end up having a pelvic enteration. These are rare, but they are too frequent to be anecdotic. So I like this aspect of the surgery, but on the other hand, obviously, it's associated to the highest rate of side effects in incontinence. But sometimes incontinence that you might deal with an artificial sphincter is maybe easier to handle than these prostate cripples. But this is something you need to discuss with the patient, and how much he likes to invest into a certain success. And obviously you need to be aware and tell the patient that you might go very far with a high risk of side effects and not achieve what you're looking for, and still the disease will progress, and this is the case in 1 out of 2 patients. And they need to be realistic and aware that they might invest a lot without having what they were actually expecting.
Totally agree, and it's back to your original point of you need to establish this at the very start before you ideally even subject the patient to a PET scan.
Yeah, I mean, even in this situation, I think the patient would benefit from a multidisciplinary consultation where they would see the surgeon, the radiation oncologist, to discuss the different options, and knowing the fact that in all the series, basically those patients have a PSA recurrence in about 50% of the cases at 2 or 3 years, whatever the local treatment is. So we also have a big problem here, although we talk a lot about PSMA. PSMA doesn't see everything, and we have progress to make in terms of selection of those patients to whom we want to provide a radical salvage option.
Thank you, gents, and thank you for your great contributions at this meeting.
Thank you very much.
Thank you. Fantastic. That's great. So I'm joined now by my good friend, urologist Dr Bertrand Tombal from Belgium. Bertrand, great to see you in person. Are you enjoying the meeting?
Great to see you. It's been 2 years.
It's exciting. Yeah. It's exciting. Are you going to come to Australia again soon, maybe?
July. I've got my ticket.
ANZUP.
I've got my ticket already.
There is another great meeting for you. The ANZUP annual scientific meeting is in Adelaide in July this year. So great to see you back down.
Yes.
So APCCC kicked off yesterday morning with a fantastic session about high-risk prostate cancer, and almost from the get-go, the topic that dominated everything was PSMA PET-CT. What were your conclusions after listening to a whole session of that from all these world-leading experts?
We are in an unstable phase where people are still thinking about should we do PET PSMA, but to be honest, the train has left. I mean, Belgium, like Australia, we know like 5-6 years down the line with the test. And the problem is not the PSMA, the problem is the doctor, is why do you ask a PSMA? I mean, that creates uncertainty because you need to apply the data you have on the new technology. But we started all body MRI in 2005. I don't think it has deserved any patient. I mean that you can still explain to people that basic management should be done according to the guideline and then refine your judgment. But I think that from a doctor perspective and a patient perspective, in high-risk localized disease, relying on traditional imaging means you're going to be blinded to 20% of metastatic deposit. Yeah, sometimes it's a lymph node, and that's not a problem. But we have cases of occipital metastases. We have cases of 2-3 centimeter metastases in the spine. So you need to know that before you start the treatment. So it's a question of exhaustivity. So, and the question for the academic is, how are we gonna re-adjudicate everything based on this imaging? That's crazy to say we should restart everything. No. And then once again, it's a technology. You don't need a PSMA for a Gillessen 6 patient. We had that discussion, and in the Gillessen 7, we have made so much progress. I probably don't need for the favorable risk. That's not going to add. But the high risk, it's 20 to 25% of patients with metastasis. So why not willing to know it? So I think the test is there. That's going to take another 5 years before we want to adjust, but I'm not scared though.
I like your summary that we're in the disruptive phase, and that's what you can clearly see. Yeah. Now, this meeting, one of the unique features is not just the fantastic faculty who are lecturing, but the consensus voting, the voting on statements. So let me throw one out to you. It's similar to one of the ones we've already voted on. You have a fit patient suitable for curative intent patient treatment. He's 60. He's got an unfavorable intermediate risk prostate cancer. Has a PET scan, and the PET scan is showing 2 lymph nodes in the pelvic region. Just 2 straightforward lymph nodes. In these circumstances, do you alter what you do? So I suppose my first question is, if he'd only had a conventional scan and did not have anything on the conventional scan, he was N0, do you do a lymph node dissection in those patients?
Yeah, I've lived with what I call European giant. One was Oosthuizer, who say, if you don't need a lymph node dissection, you probably don't need a radical prostatectomy. So I mean that we've discussed enough in a high-risk patient. A good lymph node dissection is part of the treatment. I mean, so that it wouldn't change anything, clearly. It wouldn't alter the judgment. The question really we have to revisit is the relationship between systemic treatment and radical surgery, because I've got difficulty understanding that 2 years of abiraterone has such a huge impact when you do radiotherapy, and it's not the case for surgery. So, I mean, I still, we have some work to do. What do we do with surgery? But for a patient like this, that's a typical patient. And then when you speak to the radiation oncologists, they say, we've been using the Mark-Roche formula, and we try to look on our local series the relationship between the Mark-Roche and the PET PSMA. That's roughly the same. Radiation oncologists in my country have a low trigger to irradiate a lymph node. The debatable question would be, if your PSMA is negative, would you omit treating the lymph node surgically or radiotherapy? That's more dangerous.
And this is really, for our listeners, many of them are urologists. That's the one.
You have to be careful. I would advocate that in an intermediate risk, that could be discussed, but in a high risk, there's plenty of beautiful work coming from Italy, from Stephen Junior's group, that, you have to understand you're taking a big risk for surgical and radiation therapy risk, there are beautiful data coming from many centers doing PET PSMA that recurrence after surgery is rarer in the pelvis if you had extended lymph node dissection. So to me, it's not the positive. For high-risk localized patients, it's the negative PET scan I worry about.
So this is, I think, one of the best topics that we as urologists have to discuss in the coming years. And I see Alberto Briganti's published a nice systematic review in European Urology Oncology this month, talking about the value of PSMA PET. And even as a big doyen of lymph node dissection coming from Milano, he does acknowledge that PSMA does have quite good predictive value. But I accept your point. So we still know that the sensitivity, if you compare with lymph node dissection, is about 40-50%. So we will miss the 2 or 3 millimeter lymph nodes. But my question back to you is, does it matter missing a 2 or 3 millimeter lymph node in one node when in actual fact there is no data to really, despite what you said, to show that lymph nodes improve survival?
That's really, I think that we should move away. I think for the systemic treatment, it's more complex than just lymph nodes. So we should move away with that. But 40-50% sensitivity is really where it's impossible to take a decision. And the question is, if you have a big guy, 120 kilogram, who had a two mesh repair for event. Yeah, okay. And that, I think in a patient like this, you could eventually say, listen, or he had a femoral repair. Okay, listen, PET scan negative, let's go. But if you take a 52 years old with a family history of prostate cancer, which is as fit as we are, I mean, why would you not do a lymph node dissection? I mean, that we're not speaking about doing a cystectomy. We're speaking about additional lymph node dissection. So that's where the best tool remains clinical judgment.
The last thing I want to ask you about is on de-intensification of systemic therapy. So what we've really seen in metastatic hormone-sensitive prostate cancer the last 5 or 6 years is amazing evidence to show that combination therapies work. You add something to the ADT and the OS benefits, and I think we all believe that initially docetaxel, but preferentially all these AR pathway inhibitors. And now we're seeing that what about if you have a triplet approach, if you have the docetaxel, the ADT, and an AR pathway inhibitor, data from Peace One and Arsens showing that further raises. But we know that the real-world utilization of even doublet therapy all around the world, many different things. We've just submitted a piece recently about this. This is very disappointing.
Yeah.
So on average, about 20% real-world utilization, even regardless of reimbursement not being an issue, et cetera, et cetera. And I thought one of the interesting themes that emerged yesterday was, yes, while intensification and adding more therapy clearly has some value, we could also look at it a bit the other way around to say, well, let's select our patients a little bit better and de-intensify treatment. But what's your?
So I think this is really the next important question. So you see amongst people who have done this trial, there are two groups now. There is a group that believe we should intensify patients that, despite doublet, triplet, are not responding well. Then there is a whole group of people who look at the data and say, if you look at PSA response rate, 1/3 of the patient have a PSA less than 0.2. And if you look at these patients, their overall survival and even the PFS, we're speaking about 4, 5, 6 years. And it reminds me that before all of this started, we were already discussing that with ADT. So does everybody needs to be treated until progression? And it brings us to the concept of what is the optimal treatment duration. So could we, in patients that are good responder, on PSA first and then probably more than that, and that's a great use of modern imaging technology, could we identify a subset of patients for which the treatment could be stopped after a few months, monitor? That would save a lot of toxicity, because we tend to forget that ADT is still the most toxic component of all. That would save a lot of money, and that would help discussion in many countries around the planet. And then it would change the paradigm that to say, I start light and I do escalate later on, we would switch the paradox and say, I start early
and heavy
and then I stop.
Fantastic. That's going to be one of our most important topics
Thank
as the
you.
years go by. Great to see you at APCCC and see you in Adelaide.
See you soon.
Thank you, Bertrand. Aurelius and Silke, what a fantastic conference. You must be pleased.
Yes, I think it has worked really well, and what I always like is really the interaction. So I think there was really a lot of questions, interactions, but all friendly, right? So I think it was, until now, I think it was a very good climate.
Yeah, I think you've retained the format whereby we have short speeches from the world's best speakers and then plenty of time for interaction. And it's the quality of the questions and the fact you can approach a microphone or shuffle up to somebody in the coffee area, I think makes it so interactive, so enriching. And that's why physically, everyone that we've spoken to has said that's why it's really important that this meeting in particular comes back physically, because you just don't get that level of engagement.
Absolutely agree. And one of the last live conferences was in Basel 2019, APCCC. So we were really a bit worried about, how it would work with being live again, but it exceeded expectations.
Look, we've had fantastic feedback already from guests. We're going to post a few episodes on GUcast, but everyone's already asking, okay, what's the plan? Are we doing another one in 2 years? Have you an announcement yet, or a venue, or a date? Can we come back to beautiful Lugano? Or?
Yes, we will. So since I'm here now stationed in Lugano, so we will stay here in Lugano, and then Aurelius agreed.
Yeah.
So I think it's a very nice place, and usually it's like, you say because I'm here. We have also fixated already the date, so it's coming up in the save the date. So
fantastic.
block
We'll
it in your
publicise
agenda.
that.
If
We
that's
will.
yeah, so I think that would be great.
Fantastic.
I can say 25th to the 27th of April 2024.
April 2024. Well, there you go. We've already been promoting this as the world's premier prostate cancer meeting, especially for multidisciplinary activity. Whether you're a surgeon like me, radiation oncologist, medical oncologist, nuclear medicine physician, radiologist, nurse, patients, etc. This is, in my mind, unparalleled as a prostate cancer meeting. So congratulations and thank you for looking after us.
Thank you very much. Thank you.
So I'm here with David Mathesen, who's a patient here at the APCCC conference in Lugano this week. David, lovely to see you. Thank you for your contributions. Are you enjoying being here at this meeting?
Yeah, it's really enlightening. I think it's an honour to be here as a patient, to give a patient perspective and to be able to report on research that we've done regarding patients and how they're living their disease, and helping hopefully to improve communication between them and clinicians by passing on what are the right questions to ask.
Well, you set the tone because at the very start of the conference, after the open, when the whole session is full and everyone's online looking, you were the first speaker, and you really did set the tone and showed how valuable, how important it is that all of the smart people, these innovators at this meeting, engage with patients and ask the right questions.
Yeah.
And you showed some very interesting data about how that's important. Like what matters to patients is not always what clinicians or researchers
Absolutely.
think. Yeah.
Well, clinicians naturally enough are focused on illness. Patients are focused on wellness. Even if they don't quite realise this, they're looking for a cure, obviously. If there's no cure possible, they want to have livable symptoms, livable side effects, but principally they want to live. And they want to communicate this to the clinicians to say, help me live better. Not necessarily help me live longer, but whatever time I've got, I want it to be as good as possible.
Now, what I've found before, having run some conferences in Australia, is I find it difficult to strike the balance right when you're convening a scientific conference, which is what this is, predominantly aimed at healthcare professionals, to try and get the balance right, because I've had patients involved in some conferences before, and either they've said, look, it's too nerdy doctory, and in fact, a patient said to me before, Declan, you know, the way that sometimes you all clinicians speak about a patient, like here's this patient, this example, it's almost too confronting because it's just brutally on progression, etc., etc. Whereas, you know, I think it's so important to have a role like you have at this meeting in reflecting patients' views. Have you tips for other conveners out there about how do you build patients in? I'll tell you another feedback on this. Somebody else said to me is one of the really big challenges is, and it can come from some of our fantastic patients who are in support groups, who are very involved, and they'll come to a microphone and ask a question. But it can be maybe a bit of a personal story, and it can be sometimes almost too emotional for us and the patient to listen to their outcome, etc. How do we make sure that it's a valuable experience for both patients and healthcare professionals? Because it's so important to have patients involved in the conversation.
I think one of the essentials is to have a patient rep who's a bit of a nerd himself, but who can translate nerd into non-nerd. Who can listen to other nerds, take on the appropriate bits, translate it for the non-nerds, and then translate it back again. It's really this translation idea that I think is absolutely essential to it. So I'm quite fortunate because I've got a scientific background. I was a teacher for donkey's years. I'm an academic, and I'm used to pitching my discourse to suit the audience. Therefore, I can listen to you guys. I might get lost occasionally, but Google comes to my aid without any problem. And if needs be, I can ask folk like yourself to explain it to me in sufficiently, at my level of nerd. But I can then take this back to support groups and the like and interpret it in a way that suits them. That's not patronising. It's just translating the words using appropriate vocabulary.
There you go. Nerdy patients out there, we need you. We want our fantastic prostate cancer patients, especially those who are nerdy, like David Mathesen here, to get involved in these conferences. But this meeting, APCCC, I really think, and it wasn't you, it was somebody else we had, I think, at the last APCCC.
It was Robin.
It was Robin, that's right. But it's an incredibly valuable part of this superb meeting, is we set the tone and we really focus on patients. And you hear it in the conversations we have with people afterwards. So let's see more patients at these types of meetings.
Absolutely, especially ones that are bilingual in nerd and non-nerd.
Thank you, David. Good job.
Good to see you.
Cheers.